Thank you very much. Thank you very much, Gaia, first of all, to organize this webinar. Thank you very much to the recently founded Global Surgery Committee of EUPSA, and some of the members are here in this distinguished faculty. And one of the chairpersons is also here, which is Professor Gonca Tekant from Istanbul. And I have the pleasure to chair this webinar today, which has the name Global Pediatric Surgical Webinar, Understanding of Global Pediatric Surgery. And we have thought, after the composition of our new committee in EUPSA, that we should not start too small. We should start rather big with this webinar to exchange knowledge, to present some of the projects. And I'm glad that we could appoint some of the members of our committee to give their view on the global pediatric surgery, its development, its methods of teaching and promotion, and of course, which we are very proud of, to have a colleague who is really from the field, which is Professor Basnet from Nepal. The first speaker I would like, so if you have questions, you should write them either in the chat or in the frequent asked questions. These are the two things we will always check. And we propose that we will have a round of discussion at the end of the presentations. The first presentation will come from my German colleague, Dr. Judith Stoltz. Judith Stoltz is actually a visceral surgeon, a board-certified visceral surgeon who has been trained in the universities of Aachen in Germany and is now working in a big hospital in Landshut. But she has a very special interest in pediatric surgery, and especially in global pediatric surgery, where she has already been involved successfully in some very complicated projects, and she has a huge insight into advocacy of the global pediatric surgery. And she is now, after finishing visceral surgery in training as a pediatric surgeon in Landshut, and she's a member of the International Health Associations in Germany. And the topic of Judith's presentation is Understanding Global Pediatric Surgery, Background, Scope, and the Role of Advocacy. Judith, please.
Thank you very much. First of all, thank you for the privilege to speak here. It's a topic that is very close to my heart and combines everything that I care about. So it's a special occasion. And I hope you can all see my screen. I will start having this introductory slide, and I put some pictures from my past up there. And when I think about global pediatric surgery, I think about a culturally sensitive and local needs focused approach. I think about equity, especially in access to care, but also in receiving and the perioperative care situation. And of course, now that I'm in pediatric surgery, I think about the pediatric population, which is oftentimes the ones that are not advocated too well for. So patient-centered. The definition of global surgery, so I've kept this a bit broad. Many of you might have heard it before. Global surgery is a rapidly developing multidisciplinary field aiming to provide equitable, timely, and affordable access to quality surgical care across international health systems. It is an area of study, research, practice, and advocacy that seeks to improve health outcomes and achieve health equity for all people who need surgical anesthesia care, with a special emphasis on underserved populations and populations in crisis. So what I really want everyone to understand is it's not about humanitarian aid. It's not about short mission trips or even about the single surgeon himself. It's an established academic field, and I think there's lots of things that we can do. So when talking about global pediatric surgery, some facts that you should know. In global surgery in total, there is approximately a 2.2 million lack of surgeons, anesthetists, and obstetricians in the world that are needed. And these are data from 10 years ago, because we celebrate soon the 10 years anniversary of the Landshut Commission on Global Surgery. In pediatric surgery, we focus on child health and equity and access to care. And pediatric surgery is a critical yet under-resourced component of global health, especially in low and middle-income countries where the percentage of the population which is under 15 years of age is even greater than in our high-income countries. Over 1.7 billion children lack access to effective surgical care, and up to 85% of children may require surgical treatment in their whole lifespan by the age of 15. There are major gaps, as I said, in sufficient numbers of surgeons, anesthetists, and resources, particularly in LMICs. And this translates to a reality, for example, in Burkina Faso, where there are only 6 pediatric surgeons for 9.5 million children available. But I want you to also think about not beyond the access to care, because we know that, and I've heard colleagues from the US say that it's basically two sides of the same coin. There are social determinants of health which have an impact on our patients' ability to stay healthy after surgery or to even undergo surgery, which is, even if it's given in a qualitative way, in a successful way. So I think it's very important to always keep in mind the social determinants of health and think about vulnerable groups that we can advocate for and focus on in any setting. So this, leads me to my next, my first experience in pediatric surgery was actually when I was doing my, after first year of med school, nursing internship in the Centro Médico Nacional de la IMSS in Guadalajara in Mexico. And I remember I wrote afterwards an email to the head of the department, thanking him for all the things that I had learned there. Because I had observed, for example, the first Kasai procedure ever in my life. I couldn't really understand it at the time, I think, but I was so fascinated by this tiny, biliary tract and operation. So there are common misconceptions that LMICs, it's always about rural and remote areas. It's of course not the case. They are essential, highly and very high specialized centers in many countries, and it depends on the country's situation, on how well they are staffed and how well they are equipped. And I told him that in doing this job and this interview, I really learned how to do a good job with low resources, and above all, how to treat patients well and with respect. And now that I look at this quote after some years, I also think it's important to learn about intercultural communication, because maybe someone from the US would rather prefer a translation like this, but we are a bit more humble in Germany. But it's the same thing that I mean. So I think global surgery endeavors and engagements are a learning opportunity, and opportunity to grow personally and professionally for everyone. And I take this example out of the table of content of the World Health Organization Surgical Care District Hospital book. So I was astonished to read that, and of course that's logic, leadership, team skills, and management, as well as good understanding and foundation in ethics, and a knowledge of education and how to educate others is are basic skills that every surgeon should possess, especially when you are in global pediatric surgery. So there are these 4 components of global surgery, global pediatric surgery. It's research, capacity building, care delivery, and advocacy. And they are all parts of the same puzzle, I think. And it's very important that there are synergies between these different engagements, so they are not isolated interventions from my perspective. And I think when you're young, like this was me when I was 19, 18, I went abroad to Venezuela. It's very important that at any stage in your career and life, you can gain global health experience and you will build upon it. It's like these small foot steps that I put on the faces of my friends there because I couldn't ask them for consent. And I think you need to be able to think beyond the OR, of course. When you look at the left picture, road safety is a very big issue and has a lot of impact on the trauma patients that will come into your hospital and settings. And of course, advocating for our young patients at local and international policy spaces is very relevant as well. So advocacy, I think the best organization here to collaborate with, and many of the more senior members of this of EUPSA, I think are also part of the global initiative of children's surgery. So it's important to raise awareness, mobilize resources, and influence policy for surgical equity, and to use research and outcome data to advocate for funding and policy change. But we can do advocacy at our own hospital. We can do it talking to local and national policymakers and our academic institutions, and for example, hosting discussion forums at national surgical congresses like we've had it in our German conference some months ago. And then, of course, there's the World Health Assembly, which is a yearly happening. It's actually coming up by the next week. And there's this year, for example, the UN high-level meeting of the prevention and control of non-communicable diseases and the promotion of mental health. And I think these are spaces for geeks and collaborators to, on a higher level, to engage upon. And why do we do that? And I think always about Rudolf Virchow, who had been not only an excellent physician, but he was also a social medicine pioneer. And I think about Dr. Hafdar Mahler, who was not a surgeon, but he was the first one to talk about global surgery in the 1980s. And so Rudolf Virchow said this famous quote that medicine is a social science and politics is nothing but medicine at a larger scale. And Hafdar Mahler, who I had the pleasure to meet when I was participating in the first WHO Watch event in 2011, and he was very senior by then and still very inspiring. He said in the 1980s, surgery is a practical affair. It has to be by its very nature. Does it have an underlying philosophy? I think it does. It cannot escape the political, social, and economic factors that influence all human endeavors. Social injustice is socially unjust in any field of endeavor. To give you a practical example of advocacy and connecting to care delivery and capacity building, there's the national strategies called National Surgical Obstetric and Anesthesia Plans. It's country-level strategic health policy plans, which prioritize for each country surgical, obstetric, and anesthesia care. It defines goals, targets, and interventions to improve the situation, and has a goal as health system strengthening. It's important to have these plans for resource allocation, monitoring, and evaluation, and also to guide implementation of surgical services. But most national obstetric, surgical, and anesthesia plans in sub-Saharan Africa, for example, do not adequately include children's surgical care as a priority. And only a small number of those NSOPs mention specific pediatric surgical goals, metrics, or workforce strategies. The study, and I will give you all the references, strongly recommends explicit integration of pediatric surgical services in NSOPs to ensure comprehensive and age-appropriate care. And this is a fight, I think, that we all have at the national level as well. So it's important to not to know what is going on and to participate actively in these if these plans are established. So when we talk about research and capacity building, there are a manifold of opportunities. And I think the emphasis of all endeavors should be on local community needs-based research, and also to think about expanding our methods and including qualitative participatory approaches when they apply, of course. It's important to think about also expanding infrastructure, operating rooms, equipment, supply chains, and workforce development. And again, interdisciplinary approaches, which means including also, for example, the nursing health professionals, the intermediate health professionals like district officers, physician assistants, whom I teach here in Landshut now. And I think this could have such a broad effect. And we need to create, I'm more appealing to the experienced and senior members of EUPSA to create fellowships, scholarships, grants, and also to think about creating and supporting open access learning material and courses. And then there's, for example, these organizations like the Senior Expert Service that I don't know if it exists in other European countries as well, which sends for 3 months already pensioned but experienced personnel to certain sites to teach their experience and deliver it. And on the right side, you see the PAFIS course that I participated in, and it was not explicitly a global pediatric surgical intervention, but it is in core all about it because it's based on open access teaching material, and this is what we need to easily and also much more flexibly be able to give courses on practical skills in a peer-to-peer teaching manner. And I know that in Germany, there are even students learning on how to handle their first laparoscopic skills on these models. So, and I also want you to encourage to look, if you think about community engagement and community education, to look at the Hesperian books where there's no doctor. And if you think more about professional courses online available, and maybe you want to be revising them, then you should go definitely to the site Search Hub and look for the courses. And maybe there are 1 or 2 courses that you could upload on Search Hub or apply to be uploaded. Yeah. So what is the situation? If we look at the pediatrics population, certainly in Africa, the percentage of the population under 15 years of age is the biggest. If we look at the distribution of the population around the world, most of the people live in Asia. So this means, translated to the density of global pediatric surgeons per 100,000 children, that there's great disparities within regions as well. So if you look at Asia, there's a 0.03 to 1.4 density, while the United States has 2.05, and we in Europe have 3.9 pediatric surgeons. So maybe we can spare them for some time to collaborate. And just to come back, because I really think it's important, if you cannot go abroad, this doesn't mean you cannot be engaged in global surgery. And it's when you take it from the social determinants of health and social medicine perspective, looking at my country, for example, in our country, almost 5 million children under the age of 15 who have a background of migration, which means that they have at least one parent with a foreign passport. And there's a difference between age groups. And this data is all before the Ukraine war. So it's much more likely, given that 41% of the refugees have been under 18 years of age, that this number has increased. So I think there's a population which is vulnerable in the EU, in Germany as well, that is worth to be supporting. So I took this image out of the publication of my colleague, Professor Emmanuel Amé. And I just want to remind you that when we think about global pediatric surgical interventions, it's about implementation-driven, or the orientation should be implementation-driven. There should be an inclusiveness. There should be LMIC participation. I think there should be a lead from LMIC specialists and not only participation. But if you think about vulnerable groups in other contexts, you can definitely integrate them, patient representatives, health providers. And I think it should be centered on the needs of the target population, no matter where in the world. And just 1/4 of these collaborative efforts is, based on academic specialist or high-income group, high-income country support. There are different forms of care delivery that I don't want to focus on too long because I think the time is running up. And of course, there's the possibility to have surgical outreach programs where pediatric surgical teams travel to underserved areas. But I don't think that this is necessarily an approach that we should do it. But it's much better to have people educated who can stay in the area and really know their culture and the language and the situation they work in. So if I can recommend you some resources to expand your knowledge, I would first remind you that global surgery and global health is all about perseverance and optimism. It's about community. You need the young generation to inspire you again, and you need the experienced persons to teach you. And it's very nice that I had the chance to at least have email contact to the former chief of my hospital here in Landshut, where I used to work in pediatric surgery. And Dr. Alfred Jahn, he has lived and worked in Rwanda since the 90s as a pediatric surgeon, and sometimes the only pediatric surgeon in the country. And he told me, stay on the ball, even if you have to fight for a lifetime. It's for the people who have nothing to say, but need us. So an article to read, Emmanuel M.A., Pediatric Surgical Care in Africa, a TED Talk to watch, because it might be almost 20 years old, but our perception of the world are based sometimes on the 60s, so it's still a very new topic. So watch Hans Reuling debunking myths about the third world really changed my worldview. And if you want to read a book, I can recommend Annie Manuel Byrne, Textbook of Global Health. And then you can also take a test to ensure quality in what you're doing and go to the upgrader of Katmandu.org. Thank you for your patience, and yeah, this is my presentation.
Thank you very much, Judith, for this very good presentation, covering many aspects of global pediatric surgery, including advocacy, which we would like to ask you to talk about. As we just mentioned, Gonka already mentioned again, if you have questions, just write them in the chat and we will discuss them. There's one thing I missed, because I missed to introduce myself. My name is Udo Rolle. I'm one of the EUPSA board members, and I had the pleasure to be involved in the founding of this EUPSA Global Pediatric Surgery Committee. And the second, together with me in the leading this, is Gonka Tekant, professor from Istanbul. We would now like to proceed with our second talk, and I'm glad to announce two important female doctors from University Hospital in Utrecht in the Netherlands. It's Dr. Ellen Reuling and Dr. Eva Stortelder. Both of them are fully trained pediatric surgeons. Ellen is more specialized in upper gastrointestinal pathology, thoracic disorders, and general pediatric surgery, whereas Eva is more specialized in colorectal and oncologic surgery. Eva is also a senior university lecturer in global health, so which fits very well to our today's approaches and our discussions. And both of them are really experienced in global pediatric surgery, and especially in the teaching aspects in this topic. So I welcome Eva Stortelder and Ellen Reuling from in Brussels and in Utrecht, and would like to ask them for their presentation.
Yes, thank you, Professor Rolle. Thank you, EUPSA. Today we want to present our shared passion. It's education in pediatric global surgery, and we will share our experience with building sustainable training projects, both in Europe but also internationally. And Eva and I believe that education is not only a tool, but also the foundation for a long-term impact. It's how we shape future surgeons, we think, and share medical thoughts and strengthen local healthcare systems. And through a few concrete examples, we will show how education can be a bridge between countries and between our international colleagues.
Okay, I'll take it over for a little bit here, just to have the next slide. Yes. To take it up where Judith has finished in raising the problem of global surgery. Thank you, Judith, for your nice presentation. Where we know that 1/3 of the global burden of disease can be attributed to surgically treatable conditions. This figure of the World Health Organization is quite illustrative. You see the burden of trauma only is almost double the burden of the 3 major infectious diseases globally, HIV, TB, and malaria. Injury only causes 6 million greater disability, mainly by road traffic accidents in unsafe situations in low-income settings. Again, looking at surgical disability from a worldwide perspective, these are the conditions causing surgical disability. Injuries, number one, like I just explained, followed by malignancies. But congenital anomalies are the third cause of surgical mortality and disability worldwide. We know that in low-income settings, the population is very young. 50% of all children worldwide live in low-income settings. So they are often affected in low-income settings. So also by congenital anomalies, which makes pediatric surgery very important also in the low-income setting. This is also an example that shows that very clearly. The study of the Global Pediatric Surgery Research Collaboration that was published in the Landshut in 2021. You see different mortalities in different settings around the world. Over 270 hospitals participated. And the most striking difference in mortality was seen in gastroschisis, actually. The survival in high-income settings is over 90%, like we know, like we treat it in our own settings. But in low-income setting, the survival is only 1%. This is something that really is raising eyebrows, and we believe there's a moral responsibility to share not only knowledge, but also resources with our colleagues in other settings. This is an example of gastroschisis treatments in a low and high income setting. We obtained a picture on the left side from colleagues in Uganda, the Mbarara Hospital. You see that they have improvised a silo bag with a catheter bag, and you see the great difference in supportive care and setting, hygiene, blood transfusion availability that is causing the great difference in mortality. Of course, parenteral feeding, which is often not available in low-income settings. So we do believe there is a need also to train and to help our colleagues in the other settings.
Yes, so since the past decades, the short-term medical missions remain very popular with the idea to improve healthcare. And the traveling from high income to low and middle income countries for the purpose of supporting healthcare services. Currently, the ethics of the so-called parachute missions is increasingly criticized, also by the LMSC countries. And there's frequently a lack of host country collaboration. The overall effectiveness of these missions is often questioned as they are not integrated in that local healthcare system, which is very important. And they usually do not provide continuity of care to patients, and partnership and long-term impact is very, very debatable. And additionally, doctors from LMIC can have the perceptions that foreign healthcare practitioners and practices are superior to those of them, which of course is not true. The question always remains, how do we achieve sustainability? And the most important aspect for sustainability is to retain knowledge within the country, rather than letting it fly away, as is often the case with those short medical missions. And as Nelson Mandela said, education is the key to improvement. And therefore, since the beginning of our training as general and pediatric surgeons, Eva and I have been actively involved in educational projects, both nationally but also internationally. And we think that there are several key elements in developing sustainable education projects. First and foremost, they must be based on the local need. So what do they need and what do they want to learn? And for a project to be successful, someone in the host country must feel co-responsible for the program. And that's what we call ownership. And additionally, these projects create opportunities for research development, knowledge exchange, and we definitely can learn a lot from them, and collaboration. And Eva and I would like to share two recent examples of educational projects we've been involved in, one in Europe which we call a pre-field project, and one in Liberia, which we call an in-the-field project. So in October 2024, a global surgery conference was organized by the European Global Surgery Network, which is a collaboration between two European-based global surgery working groups, the DTC from Germany and the ENSIS from the Netherlands. And the conference was designed for medical doctors and specialists from high-income countries, but especially as well for low and middle-income countries. And especially for doctors who share a commitment to addressing surgical challenges in global health. And it started with a 3-day of global surgery workshop course. And to promote inclusive participation, attendees from LMIC were either funded to join a working group or received a reduced registration fee. So the event featured a hands-on workshop, actually multiple workshops with a high variety of teachers from LMIC and high-income countries. And this gave a fantastic interaction, very interesting discussions, how you do it, and also knowledge exchange. And the workshop covered a broad range of global surgical topics, including pediatric surgery, as you can see in the first picture, but also acute abdominal conditions, suturing of bowel anastomosis, which we practice on pig bowel, trauma care with placing external fixators. But also what we found very important was anesthesia in low-income settings. So what can you do if there isn't an anesthesiologist? And laparoscopy, and also gasless laparoscopy in LMIC with the famous Dr. Ganaraj from India. And neurosurgery for the practice of boreholes, and further gynae and ENT were also part of this course. And it was a huge, huge success with over 65 participants from all over the world. And the participants rated this course with an overall score of 4.8 out of 5. But due to this success, the next cohort is planned to be in Tanzania in 2026. And I will hand over to Eva. Again, we'll show an example of an education project in the field, so in Liberia.
Yes, thank you, Ellen. So this is an example of a pediatric surgery course that we developed on demand of the John F. Kennedy Memorial Hospital in Monrovia in Liberia. It's a country in the western part of Africa. We did this together with a local NGO from Norway called Kappa Care, and of course the surgical team in Liberia. Liberia has a great unmet surgical need, so out of all acute operations that should be performed, only 9% is actually performed at the moment, so an unmet surgical need of 91%. There are also no subspecialties in surgical training, so there is a general surgical training, but no pediatric surgery training, for example. So that's why the surgical team of the JFK Hospital in the capital demanded for this training. So we work together in the Dutch Global Surgery Working Group. It's part of the Dutch National Society, the Surgical Society in the Netherlands. And this surgical society in our country created a partnership with the JFK Hospital in Monrovia in Liberia, with the help from the local NGO Kappa Care, like I just said. And together this created a strong foundation for sustainable collaboration. In different surgical topics, there is provided trainings based on local demand. So the course that Ellen and I designed and gave last April in 2024 covered these themes. And we also involved interdisciplinary colleagues from the hospital. You see here the radiologist giving a lecture, for example, and it was the first time he met the surgical trainees personally in this lecture-wise. And also the nurses we involved, and therefore creating a platform and a possibility to start discussing about these topics. How can we best treat them in this resource-limited setting? When do we ask for help? How can we best care for these babies? We try to also measure what we were doing with a pre and a post test before and after the 1-week course, and daily evaluations to also improve for further trainings. Lastly, some opportunities and future perspectives. We do believe that educational partnerships are a strong element of sharing pediatric surgical best practices and trainings. We don't have to invent the wheel all ourselves. We can make use of existing online networks and platforms. I just included 2Q4U is very interesting, relevant clinical case discussions from all over the world. And for example, Open Pediatrics is a platform with online medical education that's free, accessible. The image on the right side of a function of the pericard effusion is an example of what is available on this platform. So hopefully in the future we can benefit from education and more sustainable collaboration with other hospitals, maybe also involving our national surgical societies, like we did in the example in Liberia, and hopefully also involving this global health working group of EUPSA. Thank you so much for your attention.
Thank you very much, Ellen and Eva, for this very interesting talk, touching especially on the possibilities of education and guidance in this projects of global pediatric surgery. I'm really interested in getting some of your ideas into our working group, and for instance, this beautiful teaching module, which maybe we can also provide to other interested hospitals and countries. We are coming now to our third presentation. And as I already mentioned, we are glad that we have somebody who can really tell us about the problems. So I'm glad to welcome Professor Basnet. He's Chief Consultant of Pediatric Surgery in the Kanti Children's Hospital in Katmandu in Nepal. He is a fully trained pediatric surgeon with a great interest, especially in anomalies, and a great interest in trauma, which is related to the outline of his hospital. And we are glad to have him in our committee. And I would like to ask Dr. Basnet to provide his lecture on challenges and success of global pediatric surgery, insight from the field. Dr. Basnet, please. You are still muted, Dr. Basnet.
Your presentation was there, your voice was muted. Now it's, I think, the microphone is on.
Okay, now I think it's a great honor to be part of the EUPSA Global Pediatric Surgery, and I would like to sincerely thanks to this organizing committee for giving me this opportunity to share my experience. Hopefully, my experience will help to share our mission in global pediatric surgery. First of all, I would like to share this is the one of the highest peak Mount Everest, which is located in Nepal. If you don't know. So this is my personal thoughts that we are in 21st century. Our newborn chances of survival still depend on whether they are born. A while ago, our head speaker also mentioned about the gastrocrisis. I also feel that baby born with gastrocrisis has over 90% chance of survival in Europe. But in Nepal, most of them do not survive. This inequality is unacceptable, and it's time to address the challenges in global pediatric surgery. For the introduction, it's already mentioned that it's from the Landshut Commission in Global Surgery, is more than about 5 billion population without access to safe and affordable surgical care and anesthesia. Talking about in children, it's estimated that up to 67% of children worldwide lack safe, affordable, and timely surgical care. And although among 1.1 billion children, adults without access to such care, 65% are living in low and middle income countries. Talking about South Asia, where Nepal is located, it's 95% of population don't have access to care for conditions that require surgical management. In 2017, there is one study suggests that about 700,000 children are still in need for pediatric surgical care in Nepal. So if you don't know about, I would like to show you this. Nepal is situated in Asia. In the northern part is the China, big one is China, and this one is the India. So we are in between China and India. So general information about Nepal. Nepal's healthcare infrastructure is mixed type of public and private facilities, and we have teaching colleges also. And GDP is way low than the most of the European countries. It's about 1,377 in 2023. And pediatric surgery started in 1981 with the two general pediatric surgeons who get chances of fellowship in UK, United Kingdom. They get trained for about 1 year, and they came back and started as pediatric surgery in our center in Kanti Children's Hospital. And we have only one government children's hospital in Nepal where I work, and it is serving the 30 million population of which is 27.83 over 8 million children get service from there. And this is my hospital. This is the Kanti Children's Hospital, and it's the only government owned children's hospital. And beside government-owned children's hospital, there are private teaching colleges, hospitals. They also provide pediatric surgical care with 1 or 2 pediatric surgeons in capital. In capital, we have 6 teaching hospitals, and this is the Katmandu. It's the capital city of Nepal, and we have 1 government children's hospital and 6 teaching hospitals. They also provide the pediatric surgery. And other teaching hospitals are located in Nepalganj, Pokhara, Birganj, Jarakpur, Dharan, Biratnagar. And this there is 1 pediatric teaching hospital in each region, and they provide also pediatric surgery. Currently, there are 28 pediatric surgeons for 8 million children. But for the government children's hospital, we have only 5 pediatric surgeons. Most of the children are coming in government hospital. Talking about the pediatric anesthesiologists, we actually don't have post of pediatric anesthesiologists. The anesthesiologists who are trained in general anesthesia, they come to our hospital, they gain experience by on time, they provide the service in our hospital. In Nepal, there are 1,600 babies are born each day, and neonatal mortality rate is about 21 deaths for 100,000 live birth. It's reduced by previous year, and majority of family rely on government children's hospital. It's because private teaching hospitals are way more expensive for them, and their income are very, very low. So they came most of the time in government children's hospital. And this is the average day OPD in our hospital. We are consulting about 80 to 100 patients for 1 day. And we have limited number of beds. We have 36 general beds and 10 beds for the high dependency of post-op care. And we have 6 ICU where most of the neonates are kept and ventilated babies are kept there. And critical care cases, just like tracheostomy, fistula, gastrocrisis, are forced to wait in emergency room for days due to the shortage of bed in ICU. And this is the one of the baby with tracheostomy, fistula. The baby is waiting in emergency for some days until the beds are vacant in ICU. Our center is also providing the care for pediatric born. Our center is the only one pediatric born dedicated for pediatric born children in Nepal. So this is the one of the bar diagrams showing the burden of the diseases in this. This data is from Patan Academy of Health Science, which is one of the teaching hospital in Kathmandu. It shows that the lower GI tract has the highest more than 5 and 14 years. With the second one is the skin and soft tissue. Inguinal-scrotal is the third, and urogenital is the fourth. Talking about the operation procedure and in total pediatric case, laparotomy is the way more in more cases. Maybe it's due to the delay in arrival. And next is the incision and drainage, then herniatomy, circumcision, and other cases. One of the main factor for delay in arrival in hospital is the transportation. This blue area is the Himalayan region, where the Himalayan is very far and it's difficult to travel from there. And another yellow line is about a mountainous region. So traveling from mountainous region to capital is really, really challenging. So some of the baby have to carry the back with the basket to traveling to the nearest transportation facility, and from there they will came with the ambulance. Our ambulance from the hilly area is not very equipped with for the pediatric children. They only barely have oxygen cylinder. Without that, they don't have much facility inside this ambulance. So that's why it's a delay in surgical care lead to preventable and complication and death in just severe disease like gastrocolitis and tracheoesophageal fistula. And another thing is in our center, in government children hospital, we don't much have proper equipments for just like a neonatal cystoscope for vulgarization for posterior cervical, which lead to we do vesicostomy. And due to the lack of frozen section, we are forced to do the 3 stages for the Hirschsprung disease. If we have Hirschsprung frozen section, we can do it in single stage as you do in your center. And lack of proper laparoscopy equipments, we have to force to have open surgery for the just like cholelithiasis, undescended testes. It's better approach with the laparoscopy. Just like previous speaker, I also agree with her that typical case of gastrocolitis in our center is look like this one. We still use Eurobag for silo because we don't. There is no availability of silo in our country. The case is delay presentation. It will lead to sepsis, and we don't have total parental nutrition. So it will lead to very unwanted situation. So last year we lost 3 cases and we got 3 cases and none of could make it. And second one is tracheoesophageal fistula. So only 5 patients are survived out of 13. So it's very contrast what we observe in Europe. In Europe, I saw there is one article how to do fetal surgery for gastrocolitis with minimal emphasis and minimal invasive procedure. But in our low income setting like this, we are struggling for the survival only. So one of the main factor is out-of-pocket expenditure because we don't have proper insurance. We have insurance started in 2017 and not yet widely accessible, and average coverage is only for €700 per year. So sometimes when baby got sick, they spend a lot of money. And 62% of family borrow money with 25% interest, which studies done in Kanti Children's Hospital. So what is the systemic other things that prevent us to giving the service? Nepal healthcare budget is 5.8%, which is way lower than the criteria from World Health Organization. World Health Organization suggests of 10%, but we are only half. And we don't have national pediatric surgical policy that will give us some from the policy level. And there is a registry system in Nepal, but proper pediatric surgical registry is not yet fully developed. And we don't have proper referral system. It's only used for the insurance purpose only. So there is also another factor is motivation. Lack of motivation. We pediatric surgeon only paid €400 per month, way less than the European standard. And the Another thing is the nursing workforce. Most of them are migrating to the developed countries like America or Europe or Australia. So how to is moving forward in our center? So Nepal Health Facility Service indicate that 59% of healthcare facility, all the basic amendment available, which improved from 2015. And collaboration with international community, we are collaboration with BAPS, British Association of Pediatric Surgery, and she's Anna from UK. She gave us how management of gastrocrisis and trauma care in last month. And we also got some visitor from Germany last month. He visit in our center and did some complicated surgery, and he gave me this gift cap as a gift for this from me. And our also basic bone care training in Interburn UK also provide with collaboration with the Nepal Bone Society, and we conduct many basic bone care training all over the Nepal. And we also our center is also started pediatric surgery specialty 4 years ago, and there is already one pediatric surgeon already graduated. And Nepal Association of Pediatric Surgery also organized the second international conference of pediatric surgeons in Nepal, where the many pediatric surgeons from all over the world participate, and we share and we gain the experience from them. And solution. This we should need to for more on advocacy for the pediatric surgery in National Healthcare Plan, and more investment is needed for the expansion and quality service in pediatric surgery. And I believe that improvement in registry and referral system will help to organize and give the quality care, and collaboration with the international community for the further upgrade and training. And in my experience, it's my personal view that working in low and middle income country like Nepal often feels like working in a war zone. There is lack of proper infrastructure, not enough trained health worker, and we often don't have equipment we needed. Hospitals are overcrowded and patients who are desperate for care. And many times we are their only hope. As a pediatric surgeon more than 13 years in only government children's hospital, the work is exhausting and emotionally heavy. It's not that we cannot do the job, but doing it under this condition are incredibly hard. The only things that keeps me moving is the belief that I am serving for humanity. That's make it all worth it. But my friends, but I dream a day when no baby die simply because of where they are born. When a child with gastrocrisis in poor country has the same chances to survive as one in the high income country. No parent should ever lose their baby because of geography. Thank you. If you have any queries, I have the address there and you can contact me also.
Okay, thank you very much. I will take over from Dr. Udo Rolle from now on because he had to rush to the operating room. He got urgently called in for a case. So we would like to thank, on behalf of the Global Pediatric Surgery Steering Committee of EUPSA, all our speakers for presenting us their experiences on how those problems with global surgery can be solved around the world. And again, Dr. Basnet, who is personally living through all those problems every day in his hospital setup. I can see one question. I think the previous one was kind of quickly shown by Dr. Judith Stoltz. She was asked to share the slide again for the book article, TED Talk again, and I think she did, so I think we can pass through that one. And then the next one is from Rita Bude. She says, good afternoon, everyone. Dear Dr. Basnet, I am running a mobile clinic in pediatric surgery since 2007 in Ghana, remote areas, and we have similar numbers of morbidity and mortality. How do you recommend to overcome the infrastructure and poverty problem for families to come to a pediatric surgical hospital? So the question is for you, Dr. Basnet.
I think infrastructure and policy level, we cannot, it's the policy level from the government. But as a pediatric surgeon, we can motivate the parents to give them the quality care is the more important than the other thing, because infrastructure is and the policy level is beyond our control, and it will take a lot of time. So if we motivate the parents and to come to hospital for provide for quality care, and one thing I like to share is, if we have a good protocol for the quality care, that will help a lot. Because I observe that in low income country, everybody manages on their own way. So there is a haphazard management. So if we have the protocol from high income country and low income country in the local setting, that will give the quality care. I think it will help a lot for in low income country also.
Thank you for your answer. And then again, there is another question by Ben Martin to you, Dr. Basnet. They're asking, you are doing an amazing selfless job to keep going. Often high-income countries plan and deliver educational interventions. From your point of view, what can we do to support you most?
I think we need a lot of equipment, but it's beyond the, I think it's hard to do it. But we need protocols and sharing the protocols and how we manage the patient over here. Because I get some silo back from British Association of Pediatric Surgery last month only. We are using that, and it helps a lot. And I also get personally get the Lone Star retractor from UK also. That helps a lot for our patient, because it's not available in our country. Just a small help and the protocol and discussion, and if we need some suggestion or discuss our patient to how to manage in some scenario, that will help a lot. We need to connect each other. I think that will help out a lot.
Okay, thank you very much. I think that's all we have as questions in the chat. I just wanted to, we have an audience here that is very international. I just want to kind of summarize what we have been able to do up till now as the Global Pediatric Surgery Initiative. We're very new. It's a very new group. Actually, this is our first webinar, and we hope that we will have many more addressing the problems and the solutions that were, again, you know, suggested by our speakers today. The first initiative that we did, which was maybe the easiest, but sometimes it's important, education, as you mentioned, is a very important part of our profession. We initiated a reduced registration fee for the EUPSA meeting every year from now on for LMIC countries. So at least our colleagues who you mentioned have lower salaries, hopefully will be able to benefit from this initiative and will be able to maybe attend the meetings without having too much, you know, burden financially. And now I think I started seeing some more questions. Let me quickly address those. Dr. Judith Stoltz shared us a link, and she says this is a book designed to teach non-specialists in remote settings about basic pediatric surgical interventions. So please, if everybody could just, you know, note that link that she shared with us, that she suggests might be helpful, especially in the, you know, limited resource setup. And again, there is another question asking, what do you think about general surgeons delivering care to pediatric patients worldwide? Is there a tool to achieve this topic? I think this question goes to all the speakers. Would anybody want to address that? General surgeons looking after delivering care to pediatric patients? Anybody interested? Judith, sorry, yes, please go ahead, Dr. Stoltz.
Yeah, so I think it's an imperative to teach general surgeons and non-specialists, given the fact that there are so few specialized pediatric surgeons. But in my own experience, after having completed my adult surgical internship residency, which is focused a lot on elderly and oncology patients, and then gone to pediatric surgery, it was quite a shift, and it's not something that comes overnight, and it has to be a very structured and guideline-based process. So I think it's something that should be accompanied and guided by pediatric surgeons, definitely.
Yeah, I totally agree. I mean, I don't think that if there are no pediatric surgeons, okay, but if there are pediatric surgeons that set up, I think pediatric surgery is a total different discipline. We train for many different diseases, especially the congenital problems. I mean, if we're talking about trauma, that's where we probably unite a little bit more with the adult surgeons, but still even there we are more conservative compared to them. So yes, I think general surgeons can only be given some basic, training skills to take care of children if there are no pediatric surgeons in the setup. And again, there was a question saying, what protocols do you need? We might help you. I think the question is for you again, Dr. Basnet. What type of protocols do you need?
I think we will discuss, we cannot give more thing here. We will discuss if we exchange our information via email, and we'll tell our situation and we will manage accordingly, because we cannot utilize other countries' protocol directly to our setting. Our setting is little different also.
Sure.
And we will exchange our ideas and view through the email and through other communication.
Okay, thank you very much. Yes, again, there was an email shared with you, Dr. Basnet, if you could take note of that. Dr. Ilham Javarli wants to reach out to you. Are there any last comments that our speakers would like to make to sum up our webinar? Because I think it's time for us to just make a little, closing remarks. Maybe I could start with Dr. Judith Stoltz. Anything, Judith, on your side you would like to add?
Well, I think it's important to collaborate and synergize, and to have maybe a space where we can collect our mutual knowledge, and also to develop in an academic way these guidelines that Dr. Basnet talked about. I know that, for example, the International Pediatric Surgical Oncology Organization is focusing their guidelines also on LMIC necessities, which is a very important and very relevant strategy. And I think this can be done in other topics as well.
Thank you. How about Eva and Ellen? Would you have any last, thoughts you would like to share with us?
Yeah, definitely. Thank you all for your attention. It's great to have this webinar together. Special thanks to Dr. Basnet sharing his time, the precious time, given all the work he has to do. And I agree with Judith Stoltz that context is really key. So the guidelines should be very much adapted to the local context of the partner hospitals. So I hope we can work together on that. Thank you.
Yes, and I would like to add that we definitely need a platform for everybody to connect and to ask questions, and we will have to put it on the agenda for our next topic to arrange this.
Thank you very much. And last, Dr. Basnet, would you like to share your last?
I'm very glad to share my experience with this international committee. In my personal view, I think I am the only one with facing this problem. And now I know that many countries around the world have same kind of problem. And I'm glad that so many people are coming forward to help and discuss and further planning in future. That will be a great relief. I think thank you for listening to me and to giving my experience in the international platform. Thank you.
Okay, thank you very much. Then I would like to thank all our contributors, our speakers of this webinar. I think everybody showed very important aspects of this topic and how we should really focus more on trying to solve the problems, because we're talking about a very young generation and a big number who are not getting proper health care. And I totally agree with the parachute surgery, aid. That is something is just not going to work in the long term. We have to have, focused projects for the future. Thank you, everyone. Thank you, Gaia, for again facilitating this. And we will hope to see you all in our future webinars and our collaboration. We will keep in touch. Thank you all. And thank you for all our, people who have joined us for this webinar. Have a
Thank
nice
you.
day.
Bye-bye, everyone.
Thank
Thank
you.
you.
Bye.
Thank you. Bye.